MSC's non-invasive ventilation patients benefit from a unique follow-up program. Patients receive 3 home visits from a respiratory therapist in the first 30 days of starting therapy. CAT scores are monitored to help identify improvements or changes in the patient's quality of life. A CAT score drop of 2 points is clinically significant in a positive way. Patients enrolled in our program experience a 5-point drop in CAT scores in the first 3 months. As we know, any improvement in a COPD patient's quality of life can have a huge impact. In addition, benefits of this program for the patient includes device and disease education, wellness support, as well as a personal relationship with their respiratory therapist. Our goal is to prevent rehospitalizations and improve quality of life. If you have a COPD patient who would benefit from this robust clinical follow-up program, contact us today. Visit medicalserviceco.com/non-invasive ventilation therapy to learn more.
Good afternoon. Our second lecture in the respiratory track is being presented by Dr. Edward Warren on ethical issues and decision-making in respiratory care. Dr. Warren is the Director of Pulmonary and Critical Medicine at MetroHealth in Cleveland, Ohio. He also serves on the Respiratory Care Advisory Council for the Ohio State Medical Board. Dr. Warren is on the Hospital Ethics Committee, has served on a state task force for the development of crisis standards of care, and is also on a hospital committee working on crisis standards of care for the allocation of scarce resources. We are very appreciative of Dr. Warren helping to fulfill the ethics requirement during this year's forum. Dr. Warren's lecture has been categorized and approved with the AARC as a lecture directly related to the ethics content. And finally, if you have questions or comments for Dr. Warren, be sure to enter them under the Engage tab so they can be processed at the end of his lecture. Don't forget to complete and submit your post-lecture evaluations to receive your ethics credit.
Hi, again, my name is Edward Warren, the Division Director at MetroHealth Medical Center. Thank you very much for inviting me to speak at this forum. I will be speaking about ethical issues and decision-making in respiratory care. In the United States, approximately 1/5 of the people die in an intensive care unit. Around 20 years ago, a study that you may have heard of called the SUPPORT study, which was a large multi-center study to understand prognoses and preferences for outcomes and risk of treatments in the ICU, showed that physicians offered life-sustaining treatments longer than they would have chosen for themselves. And in truth, ethical considerations are always inseparable from the practice of medicine, and these ethical considerations, as we'll see, are often in conflict with each other. And in addition, over the last several decades, with the advent of patient autonomy and shared decision-making, the concerns of patients, clinicians, and society may also be in conflict with each other, which we will explore. Natural disasters and pandemics, such as the COVID pandemic we're in now, add another layer of complexity to the ethical issues due to a scarcity of resources needed to care for patients. And since most ethical dilemmas that we see in healthcare arise in patients who are dependent on ventilators, respiratory therapists need to understand these issues and should have a role in resolving them. So the objectives of this presentation today will be to know the ethical considerations in the ICU and respiratory care, to understand the responsibilities and rights of respiratory therapists in the delivery of care, particularly when it comes to the end-of-life care, and to understand the ethical challenges during pandemics and natural disasters when resources are scarce. The topics I will cover in this presentation will be the principles of bioethics, conscientious objection in the ICU, non-beneficial or potentially inappropriate treatments, shared decision-making in the ICU, end-of-life care, and the allocation of scarce resources during pandemics and natural disasters. The ethical principles in healthcare were established in 1979 by Beauchamp and Childress, who delineated 4 principles that should guide the ethical practice of medicine. And they define these 4 principles as the respect for autonomy, beneficence, non-maleficence, and justice. And as I said in the introduction, these principles may be, and actually often are, in conflict with each other. So first, respect for autonomy. Autonomy is the patient's right to self-determination. That is making sure the patient or the patient's surrogate is as free as possible to make decisions regarding their health care. In the past, healthcare providers adopted a very paternalistic approach to patient care, often undertaking or even withholding interventions without informing or getting consent of the patients, just doing what they thought was best for the patient. And this has changed over time and to patient autonomy. But autonomy does not absolve the provider from informing the patient of the pros and cons, nor of making a recommendation of what the healthcare provider feels is the best course of treatment. And so this requires a respectful treatment and disclosing information, which means probing for and ensuring understanding and voluntariness on the patient's or surrogate's part, and fostering autonomous decision-making as part of the responsibility of the caregivers. If a patient's refusal of an intervention is believed to result in harm to the patient, the provider should explore the reasons that this decision is being made and not accept it at face value necessarily. Often, patients make decisions because of fear of the treatment. When it's more carefully explained to them, they might have a better understanding. The second principle of ethics is beneficence, which means to help patients whenever possible and do as much good as you can. It requires that caregivers be compassionate and empathetic and sensitive in their bedside manner. And this may clash with the principle of autonomy. If a patient has not consented to a procedure which would be in their best interests, what then should a provider do? Per Beauchamp and Childress, autonomy can only be violated in the most extreme circumstances, when there is risk of serious preventable harm, or when decisions may harm others, such as a pandemic. But there is much debate about this when these boundaries cross and become in conflict to each other. And we'll see some examples of that later on. Non-maleficence is the Hippocratic oath of first do no harm. And in truth, all medicine includes some risks, and many interventions involve harming the patient. We would never be able to operate on a patient if we always avoided harm, or prescribe medications that may have harmful side effects if we were trying to avoid all harm. So first do no harm actually means avoiding anything which is unnecessarily or unjustifiably harmful. We must always ask, does the benefit of what we're doing outweigh the harm that we might be causing the patient? And are there alternative treatments with equal benefit, but perhaps less risk to the patient? Justice is perhaps the most difficult of the principles to adhere by. And when we talk about medicine, there are two forms of justice that we think about. One is called distributive justice, which involves the fair allocation of medical resources. It helps providers determine which patients get priority when resources are scarce or when multiple patients need care simultaneously. Procedural justice concerns the fairness and the transparency of the processes by which these decisions are made, and involves the right to be treated equally and equal access to treatment. Switching gears now, we're going to talk a little bit about conscientious objection. When a healthcare provider in the ICU has a moral objection to what the care being provided is. And in 2015, the American Thoracic Society came out with a policy statement regarding how to handle conscientious objection in the ICU. And what I'm going to talk about really comes out of this policy statement. And the reasons to accommodate a caregiver's conscientious objection include to protect the clinician's moral integrity, to respect the clinician's autonomy, to improve the quality of medical care, and to identify needed changes in professional norms and practices. So in other words, a caregiver might feel that a certain intervention is not moral, and this makes us reevaluate what we're doing in the care of patients in general. But there are also reasons not to accommodate conscientious objection. And these are to honor our core professional commitments. We voluntarily commit to promote the patient's best medical interest, not to abandon the patient, and to make reasonable sacrifices for the benefit of the patient's health. We also have an obligation to protect vulnerable patients and to prevent excessive hardship for other clinicians or the institution, and to avoid harmful discrimination against patients that might be unintended. So the goals in conscientious objection are to balance two ethical objectives: to protect the patient's access to legal, professionally accepted, and otherwise available medical services, and to protect the clinician's moral integrity. These two goals must be balanced. And so the ATS in their statement came out with recommendations of how to balance these goals. And they state that in the ICU, conscientious objection should be managed through institutional mechanism rather than on an ad hoc basis by the clinicians. Institutions should accommodate conscientious objections in the ICUs if the following criteria are met: that the accommodation will not affect the patient's or the surrogate's timely access to medical care or information, that it will not create excessive hardships for other clinicians or the institution, and that the objection is not based on some form of discrimination on the clinician's part. The clinician's conscientious objections providing potentially inappropriate or futile medical services should not be considered sufficient justification to unilaterally forego the treatment against the objections of the patient or the surrogate. And we'll explore this a little further. So clinicians should use a fair process-based mechanism to resolve such disputes. Institutions should promote open moral dialogue, advance measures to minimize moral distress, and generally foster a culture that respects diverse values in the critical care setting. So I'm going to go over two examples that actually I just extracted verbatim from the policy statement that have pertinence here. The first one is a 70-year-old woman who has suffered a large stroke and has been in the ICU for 1 week on mechanical ventilation and now has become septic from ventilator-associated pneumonia. The physician taking care of the patient strongly recommends to the family a palliative care treatment plan. The family disagrees, but ultimately acquiesces after the physician firmly restates his recommendation. The physician asks the respiratory therapist to extubate the patient as part of the palliative treatment plan. The respiratory therapist is hesitant to extubate after witnessing a reluctance by the family, but due to the sense of powerlessness, says nothing and proceeds with extubation. The patient dies several hours later. The therapist is very distressed that night, cannot sleep, and calls in sick to work the next day. The recommendations of the panel from the ATS state that it is important to both prevent the moral distress from occurring as well as to manage moral distress that has already occurred. In this case, the respiratory therapist has suffered moral distress from acting contrary to her moral compass. Part of this is a perception of powerlessness that prevented the respiratory therapist from acting according to her moral belief. This powerlessness may be real or perceived due to hierarchies in clinical care, but is essential to address this perceived powerlessness. An open moral climate where all clinicians are encouraged to explore their moral concerns without fear of repercussions should exist. When the moral distress has already occurred, the institution should provide support services for clinicians who are suffering from this. The second example is quite different. A 25-year-old woman is admitted to the ICU shortly after midnight with acute septic shock after first trimester pregnancy termination. The attending intensive care physician refuses to care for women whose critical illness is a result of an abortion based on his religious beliefs. In this case, there is significant risk of immediate physical harm to the patient that outweighs the risk of moral harm to the physician. The position of life-saving medical care is central to the role of the ICU physician, and the burden on institutions may be too high to ensure that there is always another provider available to accommodate conscientious objections in emergent situations. In acute life-threatening situations when a conscientious objection cannot be accommodated, the objecting clinician must provide the medical service to the patient or face institutional and legal sanctions. And in fact, these situations do not come up that uncommonly. We often see patients who might have very racist tattoos or say very discriminatory or hostile things to us, and we may feel uncomfortable taking care of these patients, but in an emergency situation, we are both morally and legally required to care for patients, even if we find that it's morally objectionable. ICU clinicians with conscientious objections to certain life-saving medical interventions that are central to the critical care profession and for which a reasonable accommodation cannot be made should not practice in a setting in which the conscientious objection will arise. So in other words, we shouldn't be in this business if we're going to refuse to take care of patients in an emergency situation. Switching gears again, I'm going to talk a little bit about the process of shared decision-making. With the concept of patient autonomy, shared decision-making emerged really in the latter half of the 20th century. At the same time, we had the development of life-sustaining medical technologies that enabled the survival of patients who previously would have died. And so there are more choices to make and more of a need to include patients and families in these decisions. Most of the conflicts we encounter emerge when a patient and families request life-sustaining therapies that clinicians believe are inappropriate given the clinical situation. So the definition of shared decision-making has been is a collaborative process that allows patients or their surrogates and clinicians to make better healthcare decisions together, taking into account the best scientific evidence available, as well as the patient's values, goals, and preferences. Shared decision-making then puts the patient at the center of care and should always be used when we are establishing the goals of care for the patient. Once the goals of care are determined, the clinician has a responsibility to use experience and evidence-based practice to implement the course of treatment that should be used. The treatment team should explain what care is being given and why, and when interventions are requested that are not in line with the goals of care that have been established, the treatment team should explain why the intervention then is inappropriate. In these situations, actually, as all of you who work in the ICU are not uncommon at all. And so, most often, these issues come up when it's the end of life, and the respiratory therapists are, as you know, are very involved when it becomes the end of life care in the ICU. The decision to withdraw ventilator support involves extensive discussion between the critical care team and the patient and surrogates. Again, it has to be in line with what the patient's values and goals are, often conveyed by the surrogates who know the patient best, and as well as the medical team's expert recommendation regarding the severity of the illness and the expected prognosis of the illness. And a couple of studies have been done that show the involvement and concerns of respiratory therapists in these situations. Although respiratory therapists are intimately involved with the care of ventilated patients and their families and are almost universally called upon for the removal of ventilatory support, they are actually very rarely involved in the discussions that lead to these decisions. And in one survey, a large survey that was done, 94% of respiratory therapists stated that they themselves participate in terminal extubations, but only about 12% speak directly with the patient or the family about the end-of-life care and what's going to happen. 11% participate in a multidisciplinary team that discusses end-of-life care, and only a little bit less than 30% are comfortable with the being involved with end-of-life discussions with the patient and or their family. And because of all this, respiratory therapists may be more likely to experience emotional and or moral distress when it comes to withdrawal of ventilatory support. And because of the respiratory therapist's unique role in the care of these patients, they have a very valuable role in comforting and educating the family with what to expect and what the process is when we withdraw ventilatory support. And I think the respiratory therapist's expertise and experience in this is often underutilized in these situations. So what is moral distress? It's defined as when a healthcare professional who has taken an oath to serve the good of the patient believes he or she knows the ethically correct action, but is unable due to interpersonal issues, institutional or regulatory or legal constraints. Most of the research on moral distress actually is in nurses, but a study done at the Baylor Healthcare System showed that this moral distress was high across multiple healthcare disciplines, including respiratory therapists. And I just showed a sample of the survey that's used to quantitate how much moral distress is occurring. And some of the questions that are directly pertinent to, I think, respiratory care, as well as all of us, is questions like, I follow the patient's wishes for treatment, even when I do not think it is the right thing to do. I follow the family's wishes for patient treatment when I do not think it is the right thing to do. I participate in starting or maintaining life-sustaining treatments when I do not think it is right to start or maintain such treatment. And I participate in withdrawing or withholding life-sustaining treatments when I do not think it is right to stop such treatment. Other questions are, I carry out orders for tests or treatments that I do not believe are in the interest of the patient. I assist a physician who performs a test or treatment without informed consent. I ignore situations in which patients or families have not been given adequate information to be able to give informed consent. I carry out work assignments for which I feel I am not adequately trained. And I work with levels of staffing that I consider unsafe. And in their study, which looked at all different healthcare providers, you can see that even among respiratory therapists, which is at the further to the right in this graph, there's a high level of moral distress among all healthcare providers who work in the ICU. And this brings us to the next topic, which is non-beneficial or potentially inappropriate treatments. When this occurs, it brings into conflict of interests of patients, clinicians, and societies. Patients want care consistent with their values and preferences. Clinicians do not want to be compelled to act against what they feel are their professional obligations. And society has interests in protecting individual rights, fostering clinician professionalism, and ensuring the fair allocation of medical resources. Patients in the ICU, as you know, are generally incapacitated and have little choice regarding their treating physicians and have limited ability to seek treatment elsewhere. And these conflicts are very common in the ICU. Physicians report that they provide non-beneficial care about 20% of the time in the ICU. And so what is the impact on healthcare workers? ICU clinicians, which includes physicians, nurses, respiratory therapists, commonly report providing care that's in conflict with their personal beliefs. They may be uncomfortable discussing options that are contrary to their beliefs, such as withholding feeding. And a survey of ICU physicians in 82 different ICUs, 27% reported acting in a manner contrary to their personal and professional beliefs during a single day of the study. The most common was providing treatment perceived to be excessively or overly aggressive. And a survey of 500 European ICU physicians felt that patients were frequently admitted to the ICU who had no realistic hope of surviving. And I think that's also true in the United States. 87% of ICU physicians in a Canadian study reported that futile care was provided in their ICU over the previous year. So a little bit about futile versus potentially inappropriate care. The term futile actually should only be used in the very rare situation when the intervention will not accomplish the intended physiologic goal. Clinicians should not provide interventions that they don't feel will be effective, and they should explain why to the patient and or the surrogates. In these situations, this is not a moral judgment, an ethical judgment. It's just a medical judgment that the treatment will not work. And examples of these include performing CPR in a patient who had remained severely hypoxemic on 100% oxygen and high PEEP and severely hypotensive on maximum vasopressors. Performing CPR in a patient like this would just be ineffective. Same thing about performing CPR in a patient who has suffered a myocardial rupture. So these are situations where the treatment just simply would not work, like giving antibiotics for myocardial infarction would not work. The term potentially inappropriate care should be used when the intervention has some chance of accomplishing the intended effect, but the clinician believes that competing ethical considerations justify not providing them. And examples, and so this necessarily involves judgment, value judgments about the quality of life predominate. And examples might be performing a tracheostomy in a patient with severe irreversible but survivable brain injury, who might be left in a persistent vegetative state, or an ICU admission for a person with end-stage dementia and organ failure. It's not that these treatments would not work, it's just that the moral and ethical factors may make the clinician uncomfortable performing these. Most of these conflicts are resolved with intensive communication and discussions regarding the goals of care. And as I said before, futile care is uncommon. It's uncommon for surrogates to request treatments that just won't work. And when they do, it should be explained to them why we cannot do those things. And in fact, short of brain death, there are no criteria or rules in which we can appeal to justify decisions to reduce life support, at least when those treatments hold even a small chance of achieving the patient's goals. And the other issue regarding potentially inappropriate care is that clinicians vary in their attitudes and beliefs about what treatment should be offered near the end of life and what treatments might be potentially inappropriate. And potentially inappropriate care is very common in the ICU. And a 2013 study found that physicians considered nearly 20% of all interventions over a 3-month period to be what they defined as futile, but was truly potentially inappropriate care. This not only is it potentially harmful to the patient, but there are financial and societal costs as well to providing this care. More than half of these cases were considered futile or potentially inappropriate because even with intervention, the physician believed that the patient's goals were unreachable. In 31% of these intervention cases, the physicians believed the patient would never survive outside the intensive care unit. And this is where shared decision-making becomes vitally important, to have these discussions with the surrogates to explain that the treatment being considered is not in line with what the goals of care the patient would choose for themselves. If these conflicts cannot be resolved, clinicians should try to understand the surrogate's perspective and create any misconceptions and misunderstandings and share their perspectives with the surrogate. If the surrogate continues to advocate for treatments that the clinician believes are inappropriate, the clinician should respectively advocate for an alternative treatment course And in this case, palliative care consultation can be very helpful to help with these decision processes. And in cases that cannot be resolved, obtaining a second opinion is often necessary. And in most hospitals now have an interdisciplinary hospital committee, which involves ethics, palliative care, legal, pastoral care, to review cases and to help with these very difficult cases. But these cases, in my experience, are very, very rare, where we cannot get a family, where we cannot resolve conflicts just with intensive discussions with the surrogates. And as a last resort, if it is possible, which sometimes it isn't, we can offer the opportunity to transfer the patient to another institution. But as I stated, it is very rare for conflicts to reach this point. So why should clinicians refrain from providing non-beneficial care? Well, because it violates two of the ethical principles that I laid out at the beginning of this presentation. The principle of beneficence, to benefit individual patients, and to first do no harm. It may also violate a clinician's obligation to steward medical resources responsibly. And there's also effect on cost of providing this care. Switching gears again, the idea of withholding versus withdrawing life support. As I stated earlier, most patients who die in the intensive care, I didn't state this before, but most patients who die in intensive care units in the United States do so during either withholding or withdrawing life support. And again, 1/5 of patients die in an ICU. Ethically, there is no difference between withholding life support or withdrawing life support treatment. A patient has the right to refuse treatment even if it would result in death. But on the other hand, a physician may not administer an intervention with the purpose of causing death, that is euthanasia. Respiratory therapists have a very important role in preparing and comforting patients and their families when support is withheld or withdrawn. And again, this is because respiratory therapists have the most knowledge about how the patient would react, with different forms of ventilatory support or with withdrawing ventilatory support, and what the family should expect when a patient is withdrawn. I'm going to talk a little bit about the principle of double effect, which has a role when we're withholding or withdrawing ventilatory support. This distinguishes between the attended and the unforeseen or unintended effects or consequences of the treatment we're giving. Consensus exists both ethically and religiously in the standard treatment of pain at the end of life. And in fact, the Catechism of the Catholic Church states that even if death is thought imminent, the ordinary care owed to a sick person cannot be legitimately interrupted. The use of painkillers to alleviate the sufferings of the dying, even at the risk of shortening their days, can be morally in conformity with human dignity if death is not willed as either an end or a means, but only foreseen and tolerated as inevitable. Palliative care is a special form of disinterested charity. As such, it should be encouraged. So we utilize this principle of double effect frequently in the ICU when patients are at the end of life. And in these situations, we use sedatives and analgesics that lead to the relief of pain, even if we know that these therapies may result in the hastening of death. But we can only use these in the situation if the good effect is what is intended. The morally bad effect may be foreseen, but it may not be intended. And this would be similar to somebody who has to end another life in the act of protecting their own life in self-defense. Obviously, ending a life is not morally acceptable, except when the benefit outweighs the risk. The risk of respiratory depression, and then furthermore, the risk of respiratory depression when administering opioids appropriately for the relief of pain or dyspnea is actually very low, and studies have shown this. And so there's often a concern that we're giving too too many opioids to relieve the distress the patient's in. But if the patient's in distress, we're not giving too much. We're actually not giving enough. And this is the principle of double effect. But we must keep in mind that the bad effect may not be a means to the good effect. Meaning, as I stated before, the good effect must outweigh the bad effect. And we must be risking death is reasonable and making a patient more comfortable only if there are no less risky ways of relieving that suffering. And in this way, the double effect is distinct from euthanasia. And just to clarify, giving somebody a bolus of potassium chloride might end their suffering, but there the risk, this is a form of euthanasia and not of relieving the discomfort associated with the act of dying. Switching gears again, I'm going to talk a little bit about what happens during pandemics or natural disasters, not national. That's a typo, I apologize. Or natural disasters when resources are scarce, which was a situation that we feared would happen with COVID. And we were on the brink of that in some areas of the country. And this requires a shift in our ethical framework. So what if we should have insufficient life-sustaining resources to care for all patients who might benefit from them? This requires a shift from a conventional individual patient-focused duty of care to a more community-focused duty of care, with goals of maximizing the number of patients who survive, both in the short and the long term. This requires a clear, fair, transparent, and efficient plan for the allocation of scarce medical resources that is grounded in a variety of our ethical obligations, including the duty to care, the duty to steward resources, and duties stemming from distributive and procedural justice, which I reviewed earlier on. The principles for allocation of scarce medical resources, abbreviated as ASMR, are that all factors utilized for resource allocations must be based on specific objective medical evidence. And this must not take into account any patient's race, color, national origin, disability, age, sex, exercise of conscience, and religion. And that no medical judgments will be made using stereotypes or assessments of quality of life and judgments about a person's relative worth. And lastly, that we only institute these policies when resources are actually overwhelmed. And so the challenges in drafting these plans, and these plans were discussed, if not formally drafted at, I think, almost all the hospitals in the state of Ohio, is to avoid unintended biases. That is, penalizing patients who may have comorbidities and a shorter life expectancy due to conditions that arose or worsened due to social inequities prior to the natural disaster or pandemic. Or patients with disabilities, or patients who are older than other patients. So just including long-term survivability introduces biases that might result in the unfair allocation of resources. And the other principle when drafting these policies is that no patient should be categorically excluded from receiving life-sustaining care. Rather, there's a hierarchy in prioritizing patients based on their survivability. I know this slide is a little bit hard to read, but this just again reviews the ethical framework when drafting these. And I keep making the same typo, I apologize, natural disasters, when developing these protocols. So it requires fairness, which is an overarching goal in developing crisis standards of care protocols that is recognized as fair by all the affected parties. Policy should reflect awareness of existing disparities in access to care, take into account the needs of the most vulnerable citizens in our community, and support the equitable and just distribution of scarce goods and resources. It requires beneficence, providing the most care, the best care for the most people. But it also requires healthcare professionals have a duty to care for the individual patient. The duty to steward resources should be dependent on healthcare institutions and public health officials who have this duty to do the most good to the most people. Healthcare providers caring for the individual patient should not be involved in these decisions. They should be kept separate. That is, the clinicians in the ICU have a duty to care for those patients, but the allocation of the resources should be removed from their decision-making process. There should be a very transparent process. The public needs to be engaged and they need to have trust in the protocols. There has to be consistencies throughout the region or the state, so protocols at different hospitals are the same at different institutions. So patients know that whatever hospital they show up in, they will be treated the same as if they went to another hospital. That the idea of proportionality, which states that when their resources are limited, this should be commensurate with the burden and with the availability of the resources. Again, it's when the resources are overwhelmed that we put these protocols into place. And the accountability should be at individuals at all levels of the healthcare system. And this is essential for building and maintaining trust. Lastly, I want to talk about the idea of splitting ventilators, which became a very hot topic for debate in March and April when there was a great fear of running out of ventilators. And this is the idea of putting more than one patient on a ventilator. And in fact, sometimes, in some cases, proposing putting up to 8 patients on one ventilator. This obviously creates problems in managing the patients and in addressing problems in one patient versus the other. And because of all the debate that was going on and some hospitals that were actually trying this out early on in the pandemic, almost every major society, the Society of Critical Care Medicine, the American Association for Respiratory Care, the American Society of Anesthesiologists, et cetera, and the nursing societies and CHEST, issued a consensus statement on the concept of placing multiple patients on a single mechanical ventilator. And they came out emphatically that this should not be attempted because it cannot be done safely with the current equipment that we have, that there are multiple physiologic and mechanical risks to doing this. If one patient's condition deteriorates and their compliance and resistance changes out of proportion to the other patients, this obviously affects the ventilation of the other patients. And there are other examples of things that can go wrong. And so this raised the ethical dilemma that if a patient can be life-saving for a single individual, if we then use the ventilator on multiple patients, risk treatment failure in all of them, or at least providing suboptimal care in all of them. Since we know that using certain ventilator settings for patients with severe ARDS reduces mortality, if we put more than one patient on that ventilator, we have no way of knowing that we are providing that safe form of ventilation for all the patients. And so we reduce the likelihood of survival for all the patients rather than saving the life of one patient. The other issue that has come up with the pandemic is CPR and emergency intubation on patients with COVID-19. And the ethical situation here is that it is essential that all providers protect themselves and their colleagues from unnecessary exposure. So there's always a feeling that we have to rush into the room when there's an emergency such as cardiac arrest or acute respiratory failure. But this is the idea that there are no emergencies in the setting of a pandemic. The the first order of business is to make sure that you are protected and that others are protected before they enter the room. This is to protect them, but also because if respiratory therapists and physicians and nurses get infected, it's going to further strain an already strained workforce available to take care of these patients. And so even if it delays the care before entering the room, all rescuers should don appropriate PPE and make sure that their colleagues are also donning appropriate PPE before entering the room. And our hospital, I'm sure other hospitals, established protocols for the delivery of CPR, outlining this. This also brings it to the forefront the idea of potentially inappropriate treatment. This calculation may change if the treatment also puts the caregivers at risk. And in addition, that the effort may divert care away from other patients who would benefit more from these treatments. And so these, again, it's the same principles of potentially inappropriate treatment, but our thresholds change, and this requires, again, intensive discussion with surrogates and with patients about what is appropriate care in that setting. So in conclusion, ethical considerations and conflicts are very common in the ICU, nearly a daily occurrence. And respiratory therapists have a central role in the care of patients requiring life-supporting therapies or nearing the end of life, and should be part of these ethical discussions, and also are at risk for moral distress because of this. During times when resources are scarce, such as pandemics or natural disasters, the ethical framework shifts from a focus to the individual to the focus on the many, that is, doing the most good for the most people. And during these times, we must be cognizant of unintended consequences in the way that we allocate resources and avoid untoward discrimination in the delivery of care. So that's the end of my presentation, and I'll be happy to take any questions that you may have.
Hello, Dr. Warren. Thank you so much for giving us a discussion around a very important topic of ethics, but also, as you mentioned throughout your conversation, a tough one at times, because there can definitely be some conflicting objectives causing us to feel like we need to make decisions one way or the other. And for clinicians, I'm sure, especially during this pandemic, it is something that has been an especially hard challenge when we talk about resources being scarce and some other challenges. So Dr. Warren, thank you so much again for the great information and talking through it. And if you're ready, we'll go ahead right into the Q&A session.
Sure.
Perfect. So when we were taking a look at the questions that came in from our attendees, a couple of questions, and a lot of them are definitely relevant with the current pandemic. And the first one, during current pandemic, should emotional distress and potential burnout be addressed proactively with your managers?
Yes, I think that's very important, actually, and have a plan in place for how to deal with burnout, and making sure the support structures are in place to handle the stress, particularly the moral distress that may occur. There's also obviously a great deal of stress in terms of fear among the caregivers themselves in contracting the disease. So it's very important to have regular communication channels open, meet frequently by Zoom or other in safe ways to discuss concerns, but also to give relief to people who are experiencing burnout and try to prevent it by having schedules that are to help mitigate stress that can occur.
Thanks, Dr. Warren. As you said, I mean, being proactive is definitely never a bad thing, especially in times like these. The next question goes along with the pandemic topic, and with the pandemic and limited supplies or equipment, how do you think RTs handled their clinical and ethical responsibility, or how do you think they should?
I'm not sure if I fully understand the question. So if resources are limited, is that what you're asking?
Yeah, so with the pandemic and limited resources, should clinicians be handling things differently, or what are some of the new challenges that might be created from an ethics standpoint as a result of those shortages?
Well, I can tell you what we've done here, and what I think is done in many places and should be done is have policies in place, first of all, at the start of this, so that we can use resources in an ethical and conservative way. But also, we're met daily with our respiratory therapists to discuss certain protocols, things that we would and would not do from both a resource limitation standpoint, but also from an infection control standpoint. Changing the procedures that we normally do, in trying to minimize the amount of time respiratory therapists need to go into the room, transporting patients, and et cetera. So these things have to be discussed, at a time and in real time often. And obviously they're ongoing issues.
Thanks, Dr. Warren. And to step away from the pandemic topic and really something that's been an ongoing challenge for probably forever in medical care, how are ethical decisions resolved when families' desired actions don't match the required medical course? And the attendee gave the example of brain death as one example.
These are obviously not as uncommon as we wish they would be, these situations, and they are very stressful. First and foremost, it's having intensive discussions with the surrogates. With COVID, bringing it back to COVID, it's been an added challenge that sometimes these discussions cannot occur in person and they're over the phone, which makes them all the more difficult. But, as I mentioned in my talk, most of the time these disagreements can be resolved with intensive discussion and with explanation. But occasionally they are not. And then as I mentioned, depending on what the situation is, it may be that we need to get ethics and the legal involved in certain cases, offer the opportunity to transfer to another facility. Obviously, that's not going to happen if it's a case of brain death. But in cases of brain death, it really just requires intensive discussion and explaining things, because that is a very difficult concept for many families to understand.
Thanks, Dr. Warren. I can only imagine in those situations, as you said, just the stress level of making decisions and having some difficult competing interests there. You had mentioned remote, and in the world that we're living in with the pandemic and the challenges that remote support offer. Has that, in your day-to-day, created any unique situations that you hadn't come across before from an ethics standpoint in terms of, prioritizing health and safety over maybe a desire for a patient to be seen in person, and just any recent challenges and advice that you could give to anyone out there on how to handle those and making that decision through the ethics lens?
Yeah, so I think that has been one of the greatest stresses, I think, for caregivers and obviously for the patients themselves and their families, is that these patients are very alone and very scared if they're not sedated about what's happening. And the family in the ICU, when we commonly have daily meetings in person with families, and they can explain things and they can see the patient and have understanding of what you're talking about, that becomes a real challenge when you're trying to do it over the phone or over Zoom. And so some of the things that can be done is to use Zoom in the room, together, with the patient and their family at the same time, so they can see the patient, see what you're talking about, and hopefully have a better understanding that way. That's not always feasible to do that, and it doesn't solve the whole problem. But I think that has been, just talking to my colleagues, nurses, respiratory therapists, and other caregivers, this has been one of the more distressing things, I think, for caregivers, to say nothing of what the stress is on the families and the patients themselves. But I think using the technology we have to make the best of this situation is the best way to tackle this.
Yeah, thanks, Dr. Warren. I know to that point, change is not easy for anyone, and there are times, I'm sure, where you can achieve the result with the technology, but the discomfort is just more so from adapting to change and what people are used to. So I can only imagine the difficulty that's led for providers when balancing safety as well as meeting those patients' needs. So thanks for talking through that. One more question. Talk about moral, ethical compass for the individual RT versus that of your healthcare organization. And what about situations if those two compete? So what your ethical compass as an individual RT versus that of your healthcare organization?
Yeah, I'm not sure. I have to think for a moment. Can you rephrase that maybe? So you're saying that the respiratory therapist does not feel comfortable with the approach of the institution or policies of the institution, or when it comes to an individual patient? I'm not.
Yeah, so the instincts and the obligations from a respiratory therapist, from an ethics standpoint, if you are in a situation to where you feel like your instincts towards ethics as a respiratory therapist compete with what your healthcare organization is asking you to do, how do you handle those situations? What's the best way to approach that?
Well, I think the best way to approach that, again, is having an environment where all the caregivers feel comfortable voicing their concerns to their superiors and to, who can then involve whatever personnel are responsible for those decisions. But you have to have an environment that where the caregivers, respiratory therapists, or any of the caregivers feel empowered to do that and feel comfortable doing that. And that requires a very supportive atmosphere, one in which communications are very open and transparent. I think you run into problems when there isn't transparency. You don't know why certain decisions are being made. And I think once, the institutions, if you understand why the institution is approaching something in a certain way, why decisions are being made, you may feel differently about it than you do initially. And so I think transparency and open communication is the only way to really prevent and to resolve those types of issues.
Thanks, Dr. Warren. I think, to really hit on that again, you've talked in all your answers about the importance of communication, proactive communication, transparency, and when it comes to ethics, I think you've made it definitely very clear that you can never have too much of that when trying to make these difficult decisions and coming to the right decision based off of all those factors. So thank you so much for answering all these questions that I think are very important, as well as all the time and work you put into the overview you provided. It's been very helpful and definitely generated a lot of great discussion. Dr. Warren, we've come to the end of the Q&A session and can't thank you enough for your time and your support of the JSM Forum. And thank you again for everything that you've done to help educate all of us and continue to move our clinical roles further as we attend events like this. So thank you, Dr. Warren.
Well, thank you for inviting me. It was my pleasure.
And for the attendees, thank you again for attending this session, and hope you got as much out of it as I did. If you can go ahead and plan on clicking over to the next session in this track, we'll go ahead and get that session starting in just a moment. So thank you very much.